Debbie, thanks so much for being here. It's great to see you.
Thrilled to be here. I'm thrilled that you all are here too, and we're not on a Zoom.
And these are familiar faces from
Yes.
a long time back, I think. Obviously your role in PEPFAR, you were driving a lot of the global health agenda, and I was just sort of speaking about this moment when you stepped out of that role and into the role of...
Well, I kept that role because,
Excuse me.
You know how I am.
Yes. Yes, of course. But refocus your attention or focus your attention on the pandemic response from the White House. You've written this book, which goes into great detail and is from a reporter's perspective, it's all the things that I wish someone had told me at the time so that we could have scooped your book. But unfortunately, I understand why that wasn't possible. Let's just jump right into it and address the elephant in the room. A lot of the media coverage of your book has focused on this question of, did you prolong a broken pandemic response by being part of it, or did you work nobly inside of a broken pandemic response to fix it? I'm really curious to get your latest thinking on that question, but maybe more for this audience. You were a global health leader. You stepped into this role in the White House. Did you miscalculate the translatability of that global health experience within the context of the Trump White House?
So I'm going to start there because that's really an incredible question. And I kept saying to myself, why are they asking me to come? Because I said no many, many, many times. But
sorry.
And I was in South Africa. We were in the middle of our big PEPFAR meeting, which is so important to me personally. When you work in Africa and Asia, but for the Global Fund and PEPFAR, you realize what a pandemic can do and how destructive it is. And when everybody kept talking about containment and following people with symptoms, and I knew that wasn't going to work, I kept sending that to the colleagues that I knew that were on the task force, but nothing was happening. And finally, they just said, it's not going to happen unless you come back here and push. And I think, in my perspective, I just thought it would be no different than what advocates do every day. They stay and fight in their countries when it's really hard. And they stay and work with governments that are very dangerous for others. And I think that was important to me. Plus, I knew if I didn't, what the options were, and you all saw what the other option was. It was Scott Atlas. And so it wasn't a matter of maintaining the status quo. Those of you who know me know I came back with a list of 5 things. I always have lists that we have to get done. Every PEPFAR meeting, I have a list, a very clear list. And I knew that there are policy adjustments we had to make, just like I knew there are policy adjustments we needed to make in sub-Saharan Africa. And we got 90% of those over 7 years. It was tough, the last one being informal fees that everybody said in West Africa would never change. But you can't accept that. You can never accept the status quo as the way things are. So I didn't accept the status quo of our pandemic response. And number one on my list was communication, consistency of communication, because that's all you have in a pandemic when you don't have other tools. And then getting testing up. Because I'm going to be frank, I was horrified that the United States had not expanded testing when every other country had. And we had stayed in this mode. We were only going to test through our public health laboratories. Now, you probably don't even know where your public health laboratory is. And I thought that was a moment in time, and our agencies would have learned. But it's the same thing they did with monkeypox. So we're not learning. 2.5 years in, we did the same thing with monkeypox. We were going to test only in our public health laboratories. I don't know any gay man who knows where the public health laboratory is. It's like they don't realize that you have to talk to the community. And you have to make it so the community can utilize the tools. It's not slogans. It's about implementation.
Yeah.
And I think that's the one thing that you all have. You all know how to implement. Believe it or not, our agencies have been so far removed and so ethereal that they no longer know how to implement things domestically.
We're going to dive into a lot of that, particularly this question about what's wrong with the institutions that exist today and what needs to happen to allow them to be in a position to provide pandemic preparedness in the future. But let me just push on this. You were known as someone who would get things done at PEPFAR. I think in the book you write about that a lot, your willingness to push, your willingness to have the difficult conversation, to be in a room with a world leader who's saying something completely wrong and crazy, and to find a way to correct that action and that message. What was different in the White House? Was it simply the persona of President Trump and his team? Was it the way that that institution functioned and its culture? Or was there something else going on that made it more difficult to be that person?
Well, you can see it in the, I don't know how many are watching the January 6th committee. And I feel for the people when they're talking, and I actually feel for Scipione and the Department of Justice, but they only had to do that for 2 months. We had to do that for 12. I mean, it's exactly what is being described is exactly how the White House functioned. There were all of these people always coming in from the outside, walking into the Oval Office and, spouting what the president wanted to hear. And then that would come back to me of saying, experts say, say, we can do it this way. Now, fortunately, I had Vice President Pence, who, when I said to him, what worked in PEPFAR, what works with malaria and TB and HIV is getting it to community levels, so let me go to the communities, and let me go to the governors, and let me go to the mayors, and I'll work at that level. Because by that time, Scott Atlas had amazing influence in the Oval Office, and I wasn't going to change the president's rhetoric, but I could change how we programmed on the ground.
I want to highlight what you're saying there, which is that the programs that the US government leads and implements in low and middle income countries to tackle other pandemics, HIV, tuberculosis, and malaria, had, as you write in the book, oftentimes better data systems,
yes,
better implementation,
yes,
and better understanding and knowledge and communication from the communities where they operated than what you encountered when you got to the White House and saw the situation in the United States.
I kept saying, where's the secret data? There has to be. I literally got an Excel spreadsheet that said case numbers on it. Static. No. I was like, this is it? This is all we have? So I think, and then I started digging. Why don't we know why people are flu hesitant? We've published now, I went back and counted, there are 20 papers on flu hesitancy, defined with age groups.
This is people who are hesitant to get a flu shot?
Yes. Okay. Race, ethnicity, gender, where it's low, no programs implemented. Data for publication, not data for implementation change. And I think that's what you see in HIV, TB, and malaria. And that's why if you work with the community, you realize data is worthless unless you're using it to improve the lives of the people you're supposed to serve. And so the fact that we were 40 years into measuring low vaccine uptake across the South in every red county, this is not something new. We did nothing to change it. We did no on-the-ground programming. Now, can you imagine, you probably have heard the slogan, test and start now with Paxlovid. Imagine if we had done that with PrEP in Africa. Don't worry, just go to your pharmacy, it's there, get tested. Or if we said to people in Uganda, don't worry, just go down to your local pharmacy and get those HIV drugs. That would have never worked. You have to develop relationships with the community and ensure that they understand the data and the science so that they're empowered to actually advocate and get what they need for their own health. We've missed that whole part here. And I know it's hard, but we're 2.5 years in and we haven't changed vaccination rates in certain areas of the South. Instead, we just keep showing that they're dying more frequently there. That would be like me saying, isn't it really sad that the Luas are dying at a higher rate? And I hadn't dug into the data and found out that they had about 10% of the investment and the infrastructure and the programming as the non-Lua areas. I mean, we're not fixing what's wrong.
Do you have a working theory for why that has happened in global health but not in domestic public health in the United States? Is it American exceptionalism or what is it?
I think there's a lot of that. I mean, when I used to say, you know, this is how we did it, everybody in the entire task force would roll their eyes. Like, there's Debbie talking about what's happening in Africa and Asia. But I have to say, if anything really helped America, it was two things. One, the people who did work on global health who came to help. Because we got databases up within 6 weeks. We had testing up in 2 weeks. So I know that if you had asked the private sector that they would have done it. I remember when I first came and asked people to start really putting in their data, everybody told me the partners wouldn't do it. 100% of the partners did it. So when I went to the hospitals, all 6,000 of them in the United States, everybody told me, the CDC told me that hospitals will never give you data daily. And I'm like, I need data daily of new admissions so I know what people need remdesivir and now need, you know, whatever they need for the, and they said it will never happen. I had 96% reporting within the first 2 weeks. So people want to help. And I think that's the part that we seem to have created this roadblock between the public and private sector and assumed that the private sector doesn't care and only wants to make profits and doesn't want to help. Yet in PEPFAR, they helped us with our Dreams initiative. They helped us with the Men's Start initiative. Every time we had a big gap, they came and helped. And I think people here assumed that they wouldn't help. It was a pandemic driven by assumptions and perceptions rather than data and science.
Did coming to some of those disturbing realizations ever cause you to rethink your decision to work on the global front instead of working domestically?
You know, when we started going to the States, I was actually really disappointed in myself because I had spent more than 20 years building infrastructure in resource-limited settings, and I found settings in the United States worse than what I found overseas. And the fact that I didn't have that situational awareness, the fact that I didn't bring that group with us, tribal nations, half of them have less healthcare facilities than Uganda, Malawi. The South. The South has dollar stores, but they don't have primary care any longer. They're an hour and a half from the closest hospital. Their community hospitals closed a long time ago, and their local physicians are all gone. And so when people, I would laugh when I could hear people get up in Atlanta and Washington and say, just go to your local doctor and talk to them about your vaccine status. And I was like, there's nobody there for them to talk to. They're not going to drive an hour and a half to an ER. They do that when they have a broken bone or a heart attack. I mean, it's like they've lost touch with what's happening on the ground here, which tells me that they're not listening.
Yeah.
In a real way of I'm listening, I'm hearing, and now I'm going to modify what I do.
And I'm recognizing what the actual problems are that people are facing in their daily
So now I'm committed to that. I'm committed to working on rural health and tribal nation health. I think we have the lessons of what works, and it's not expensive. It just needs to have the will to do it.
You mentioned that you brought in the global health people to sort of, actually get the data together and to start to build something that looked more familiar and more appropriate to the challenge. What was that process like? I mean, I know that these institutions can be a little bit territorial at times.
Yeah, it was amazing to me. These people called me up and said, can I come and help you? And it was people from PEPFAR, people from USAID, people from the US Digital Services, people from OMB. I know if you're in the federal government, OMB is scary. They came and helped me. So, I was inspired by the grassroots willingness to really jump in and help. And then when I got into the States and worked with the governors and mayors, they wanted to do the right thing too. I mean, I didn't find anyone, even in that first several weeks, even President Trump was willing to do the 15 and 30 days to slow the spread. So, I mean, I felt like we were getting momentum, and then, of course, then the Clorox moment happened, and we had no momentum after that.
Yeah, we actually, no, I'm just kidding.
No, yeah. Let's show it again. I've only seen it about 4 million times.
Yeah. Okay.
But think of Scott Atlas as Rudy Giuliani, and think of this DHS scientist as one of those people that said, let's go get the election machines. I mean, this is the kind of thing that would just happen. Someone would walk into the Oval Office. In that moment, I was really worried about the mental health of young children because my daughter had 2 children and she was pregnant, and every mayor closed the playgrounds. And I thought, well, if we can convince the mothers that sunlight works as well as Lysol, they'll let their children go outside. So that's all the DHS scientist was supposed to do. He was supposed to compare the ability of sunlight to kill COVID to Lysol to kill COVID. And now you see what happened.
Okay.
But, you have to keep working. I mean, you just can't stop. That was a horrible thing. We lost incredible loss of momentum, loss of trust. I mean, I could see everything. When you see me looking at the ground, it's me watching the whole program unraveling.
I mean, I think we knew that. We could see that. Do you know how many times the word data appears in your book?
I hope more than any other word.
Probably. It's 691 times in a roughly 500.
Only if you use data for decision making and then actually make the decision, do the policy change, and implement the policy change.
Well, this is why I bring it up, because I've interviewed you several times in your previous capacity as head of PEPFAR, as U.S. Global AIDS Coordinator. And you've always been driving the data message and been driving the message that you can't do anything unless you have the data that shows why you should do that thing.
And if it's working.
Yes.
Yeah.
Right, and having that feedback cycle. Yeah. And correct me if I'm wrong, but I think a central message of your book is that not having the data at the beginning sort of opened the floodgates to mischaracterization, to competing political agendas, to mixed messages that lost public trust. I guess I'm just curious if you still have that faith that knowing the facts, that having the clear picture really can lead to the right policies and good implementation.
Yeah. Because
your faith in data is still...
Because I lived it in Africa and Asia. And let's face it, there were a lot of African presidents that didn't want to talk about LGBT issues, that didn't want to talk about what was really needed on the ground. But in the end, they adjusted, in many cases, their policies. I mean, we still have to work on criminalization, and there's still issues to be done. But every Republican Southern governor changed its policies based on the data. Ducey put in a mask mandate, closed his bars, restricted indoor dining to 20%. Governor Abbott did the same thing. Governor Ivey in Mississippi, Governor Tate Reeves in, Governor Ivey in Alabama, Governor Tate Reeves in Mississippi. John Bell Edwards in Louisiana was already doing it. But so data does change people's minds in a way that's transformational. But it can't be one-offs. I mean, obviously, I had to go in person many times, but I also was on the phone constantly saying, look, doing this resulted in that, that's great, so we have to keep that up. And I think what we've evolved into is a pandemic response by polling. And I think because COVID is polling, if you've watched the New York Times, polling at like 0, no Democrat or Republican wants to talk about COVID, and therefore we're doing exactly what Scott Atlas advocated for. We're just letting the virus rip across the United States, and we are not putting the programs into place, even though we have the tools to really save people's lives. And, data allowed us to see people, no matter where they lived, and to understand then that we had to meet with them and find out what they needed and to ensure their access to the program. And I think we are not doing that in the United States. We're doing it where it's easy. Remember the early days of PEPFAR and the low-hanging fruit? Imagine if we had stopped there. Imagine if we had said, that's good enough. We feel good about that. We feel good we got to the low-hanging fruit. So yes, if you live in New York City, you can get test and treat anywhere. I've been up there. It's in the sidewalk. You have access. If you go to rural Mississippi, rural Alabama, rural Louisiana, rural Georgia, no, you don't. Yet why aren't we putting money and resources and figuring out how to implement a plan for rural Georgia and rural Mississippi? It's easy. You have a list of every single person in the United States over 65 and everybody with immunodeficiencies. You're all registered in Medicaid and Medicare. We could send tests to the house with a hotline that said, if you test twice a week during your surge, if you're positive, we'll get you Paxlovid. That's how you implement a program. You don't say it's at Walgreens, go drive there, when the Walgreens doesn't even exist in those rural counties. Dollar stores exist in the rural counties. So if you want to do it through a store, you got to go to the dollar store people and ask them, because there are dollar stores in every rural county, because we drove 25,000 miles across the United States, so I know what's where. But it's like we've lost track of what is happening in urban versus rural areas and community by community and race and ethnicity, and we're not funding where the problems are right now. And I think I can't imagine what that would have looked like with HIV, TB, and malaria if we had stopped with the low-hanging fruit.
Well, let's talk about that global picture, too. I mean, you rightly pointed out at the beginning that you were still the U.S. Global AIDS Coordinator, and apologies for stripping you of that title. I didn't mean to. When you were in the White House, watching everything unfold in the United States, what were you thinking about the global response at that time as well? We've talked a lot about how these systems are in place in other countries, but there's also a deeply flawed global response to the COVID-19 pandemic, and I don't want to give the impression that everything is great everywhere else. So how are you thinking about
I'm really proud of the PEPFAR team because, and actually at the White House in that moment in January when I saw what was happening, and it was clear to me that there was going to be a lot of aerosol and asymptomatic spread, I called Erin Walsh in the White House in the National Security Council and said to her, we got to get all the African diplomats together because they have to know this is really serious and it's going to be a huge problem. And so we called a meeting in the Indian Treaty Room. All the African diplomats came in January, and I said, use whatever PEPFAR dollars you need. We have human capacity. We have laboratory capacity. It's the same lab platform. Thank goodness there was HIV laboratory development in sub-Saharan Africa, because then they had the platforms to actually do COVID tests. John came down from the African CDC and gave a talk.
John Kangasong.
Yes, because we were in Africa all together. So every first day of the PEPFAR meeting, we talked about COVID. And John talked about COVID and came down and talked about COVID. So I think, I felt like I was mobilizing in Africa and Asia, watching the United States say, 10 cases, all contained. I mean, Africa hadn't even had its first case yet. I was like, it's a pandemic. It's going to get everywhere. I don't understand what people were thinking.
And so does that vision...
But we're still thinking that way today, like monkeypox. It's going to be contained, only a few people. Let's not show...
So you're not seeing any institutional learning at all?
Are people still dying in red counties? All right, 2.5 years later, that's inexcusable. I don't care. Don't make an excuse of how they voted. I don't care how they voted. I mean, that was like when the president of Kenya said to me, those are just the Luas. Like somehow that didn't matter because they were the opposition. We're Americans. If someone has a problem and our systems are not working for them, that's our job as federal employees, is to work with states to fix the systems. That's our job because we can see across the whole country.
I want to get to this PEPFAR piece. You said that you mobilized PEPFAR to pivot, to do whatever they had to do to respond to COVID-19. Is that the vision for where we go from here? Next, you mentioned John Kangasong. I'll be speaking to him shortly after this. I know you had unfinished business at PEPFAR. And part of the question, I think, is, does that remain an initiative focused on HIV? Or is this sort of model that has played out during COVID where you take that platform and use it for a broad swath of health systems needs? Is that sort of the future?
Well, what was clear to me early on is you can't respond to HIV without improving the health system. And I think PEPFAR did and still does a lot of funding in the health system. And John led most of that when we were building lab capacity in sub-Saharan Africa. And that lab capacity is actually quite good. Yes, there's unfinished HIV business, but I can tell you what DREAMS taught me. DREAMS taught me that when you put the client at the center and you deal with the structural issues that put young women at risk, you have to work beyond. We had to work in education, we had to work in bridge to employment, we had to work on human rights, we had to work on legal frameworks, we have to work on communities' perception of young women, we had to work in the school system, we had to work with community chiefs to ensure that young women were not married before the age of 18. So PEPFAR has been driven to answer the needs of people at risk for HIV and also having acquired HIV. And I think when you do that and you do it right, then you're building with community systems that can respond to any pandemic. I say to people all the time today, stop worrying about the next pandemic. Let's get this one right and have less people dying. And if we get this one right, we will have the systems in place for the next one. And I think that's what PEPFAR and PMI and MCC has done. They put systems in place that are there for COVID, but are there also for other pandemics. And I think in the US, we haven't built that coalition between the private sector healthcare delivery and federal responsiveness on a generalized public health response. And I think there's a willingness on the private sector side. I just think we're not engaging them.
You level a lot of criticism at the public health institutions, the US government's public health institutions. I wonder if you think that they can be pushed in the direction of being able to provide the kind of pandemic preparedness, or even to, as you say,
they can, or I wouldn't have written the book.
Right.
Because there isn't any point of pushing someone you know is going to fail. So I believe that there's incredible people at the CDC. They have just gotten into a very isolated and insular status. Probably there's less than, before COVID, there was probably only 50 people in the States. So I think they've lost that connection about the reality on the ground. In order to re-engage, they need to be held accountable for the state of our existing pandemics: obesity, diabetes, hypertension, opioids, and then of course the current infectious disease pandemic. And when they engage with the states, engage at the county level, engage with the community, and move that needle, yes, it's going to take time. But so many people told us in PEPFAR that we would never be able to control the pandemic. And then you look at rates of new infections, and they're the lowest they've been since 1990. That was the vision that the governments had with the new SDGs. So I think the vision in the United States is we should be responding to our current pandemics in an effective way and hold our institutions accountable. And if they're not effective, they will become effective if they're held accountable. They're good people there. I think they just became very focused on outbreaks, and an outbreak is not a pandemic. And the things that work in an outbreak, one-offs, don't translate to the constant engagement and use of data that you need to control pandemics.
And you mentioned that your focus going forward will be on
rural health and tribal nation health.
In the United States.
Yes, because we have solutions that we learned globally. And I think that's my other message. Stop this belief that things that happen outside of our borders aren't important, because that's where I learned. I mean, that's where I learned, and that's where I learned to respond to the pandemic and COVID and being able to work with communities. I mean, learn this. Learn from the advocates. Learn how to work on the ground in a grassroots way. Fund local community outreach organizations that know how to rebuild trust in a fractured way. There's no trust because there's been zero federal support in the healthcare group. Yes, there's pockets. HRSA's done a great job in some very rural communities. But if you look across the United States, I mean, there's only 25, I think 538 HRSA clinics in tribal nations. That's a drop in the bucket. We had 60,000 sites in PEPFAR for a population, maybe 3 or 4 times the United States. But
so learn from global health.
Learn from you all have a lot to teach domestically. I don't know why we haven't listened to the people who have actually been implementing programs.
Well, that's a good place to end. Thank you, Debbie.
Great,
Appreciate it.
great to be here. Thank you.